Hello there and welcome to this session. My name is Malcolm MacLeod and I'm Professor of Neurology and Translational Neurosciences at the University of Edinburgh, and I'm going to talk about evidence for and origins of poor rigour in research before Thomas Steckler talks about things that we might be able to do about it. I've got no relevant financial conflicts of interest, with a relevant background in vitro and in vivo research, in clinical trials, systematic review, meta-analysis, some background in drugs regulation, in research improvement, and I've been coordinator of the guarantors of GoEQIPDv3 from 2021 until earlier this year, 2023. And the basic problem with research, I think, can be summarised in one slide. So this is a road sign from Wales. It says no entry for heavy goods vehicles, residential site only, and underneath it says the same thing in Welsh in case there are any truck drivers who can't read English. And we've got a similar thing in Scotland, where we've got bilingual road signs around some of our poorest communities because it's cheaper to put up a road sign than anything else. Actually, this road sign says, "I am not in the office at the moment, send any work to be translated." So this translational road signist, if you like, hasn't understood the underlying technology that they're using. They've taken their data string, they've sent it off to get processed, they've got their data string back, and credulously they've believed what they've been told rather than spending some time to understand, to validate if the result is really true. So here's an example. This is a technique called functional magnetic resonance imaging. It is a way of identifying regions of brain that are active for particular tasks. And it relies on something called the blood oxygen level dependent signal, that when a bit of brain is metabolically active, it creates byproducts of metabolism which causes a venodilatation, which can be detected on the scan. These scans, as you might imagine, are quite temperamental. They need to be set up, trimmed, and fiddled with and adjusted to make sure they're running properly. And this group in Boston had a competition to see who could bring in the most unusual piece of organic material to put in the scanner every week before they got on with their work. And one morning it was Craig's turn to bring something in, and as he was walking to work he remembered that it was his turn. He didn't have anything, and he thought, well, no one's had a fish in the scanner before. It might make the scanner smell for a day or two, but it'll win the prize, and the prize was free beer at the work barbecue, so worth having. So they came in, they put the fish in the scanner, they twiddled the knobs, they got it all trimmed and ready to work. And then their healthy human volunteer for that afternoon didn't show up. And Craig's genius was to do the experiment on the salmon. So one mature Atlantic salmon participated in this fMRI study. It was 18 inches long, weighed 3.8 pounds. They didn't know whether it was alive or dead. They didn't know whether So one mature Atlantic salmon participated in the fMRI study. It was about 18 inches long, weighed 3.8 pounds. They didn't know if it was male or female, but like most neuroscientists, they weren't that concerned. And the task administered to the salmon involved completing an open-ended mentalizing task. It was shown a series of photographs of human subjects with a specified emotional valence. They were happy or sad or perplexed. And the salmon was asked to determine which emotion the human in the photograph was experiencing at the time. Several active voxels were seen within the salmon brain cavity, and you can see them here, with a cluster level significance of less than 1 in 1,000. So as they conclude, either we've stumbled onto a rather amazing discovery in terms of post-mortem ichthyological cognition, that's to say that dead salmon can think, or there's something wrong with the unadjusted statistical approach they were using, and of course it's the latter. And in fact, the complexity of the imaging paradigms here are such that there's something like 100,000 different ways of analysing these data, and if you analyse them that many ways, then you're bound to find something which reaches significance. And for this work they were awarded the Ig Nobel Prize in Neuroscience in 2012, and rightly so. Now, of course, that's brain imaging, but we know that proper bench biologists wouldn't make that sort of error, would they? Well, this is an experiment actually from NIH looking at the effect of low-dose glutamate in a rat model of focal cerebral ischemia. You can see that in the control situation there's about 200 cubic millimeters of infarct, reduced by about 15% in half-dose low-dose glutamate, and reduced by 40% with full-dose low-dose glutamate. Standard neuroprotective effect seen for thousands of drugs. But when I tell you that half dose is 10 to the minus 120 molar and full dose is 10 to the minus 60 molar, then those of you who remember Avogadro's constant, 6 times 10 to the minus 23, 6 times 10 to the 23, will appreciate that there isn't actually any glutamate in either of these pillars. So this is water against water against water, and this effect cannot be real. Even if you believed in homeopathy rather than the precepts of conventional medicine, then under the homeopathic paradigm, this 10 to the minus 120 molar should be the more powerful treatment, being the more dilute, and therefore this doesn't fit either with homeopathy or with conventional biomedicine. It's just frankly wrong. And in fact, some years ago with Torio Collins in Melbourne, we were interested in identifying drugs that might work in stroke, that were already known to be safe in stroke, that we might consider giving to patients in the back of an ambulance, shortening the interval between stroke onset and treatment, which is held to be one of the critical dimensions of effective therapy. And we found over 1,000 compounds that had been tested in the laboratory in models of stroke, of which over 600 had been tested in that focal cerebral ischemia model of which I spoke. Remarkably, almost 400 of those improved outcome in that focal ischemia model. So lots for clinical trialists, as I was at the time, to be chewing through, to be getting on with. And in fact, 97 drugs at that time had already been tested in human clinical trial, of which one, clot-busting treatment with tissue plasminogen activator, actually improved outcome. And TPA had been tested in human stroke, not because it works in animal models, although it does, but because it was effective in humans in a cognate condition, myocardial infarction, caused by occlusion of the vascular supply to a critical organ bed. And against that, we've got 3 conditions which have been tested in humans and effective in humans: decompressive hemicraniectomy, stroke unit care, and aspirin for the acute treatment of stroke, none of which have been developed through animal models. And so depending on how generous you're feeling here about TPA, the attrition rate is either 100% or 99.7%, but either way it's not good. So why might we be seeing this failure of translation to the clinical space? Well, here's the example of a drug called NXY059, which was developed by AstraZeneca for stroke and tested in a clinical trial program, which unfortunately at the end of the day showed that it was without effect. And we went back with the benefit of hindsight and looked at the animal data in the public domain about this drug. 11 publications describing 29 experiments involving 400 animals for a drug where the clinical trial program involved 5,000 human animals. And it improved outcome by 44%. This grey bar is the 95% confidence limits of the estimate of efficacy, and you see it's highly effective. But when we look at those studies which reported measures to reduce the risk of bias, whether the animals were randomized to treatment group, whether the investigators were blinded during the experiment, whether the assessment of outcome was done blinded to treatment group allocation, then that efficacy, the effectiveness is substantially and significantly lower in those high quality studies at low risk of bias. And critically, the 2 animal studies that were cited and used by the company to justify the clinical trial actually had not done any of these 3 things. So why might blinding be important? Because sometimes, the assessment of outcome here is measuring around an infarct volume. How might that be affected? Well, this is Robert Rosenthal from 1963, before even I was born. He taught a course in graduate psychology, and at the end of the course the students had to do an experiment. The experiment ran over 5 days, and it involved comparing cognitive performance in 2 cohorts of rats. One, the Mays Bright animals, were from a colony at Berkeley which had been bred and selected for over many generations for good performance in cognitive tasks, although these animals were naive to this particular task. And the Mays Dull animals were their slightly dumb and duller country cousins, if you like, inbred over generations for poor performance. And the task was pretty straightforward. It's a T maze. The rat is put in the stem of the maze One arm is lit and the other is not, and the arm which is lit is flipped according to a predetermined random schedule, and the unlit arm is always reinforced with a food reward. So the animal, rather like our junior faculty, is being trained to turn to the dark side. And this is what happened. The maize bright animals started off performing better than the maize dull animals. And for a few days that separation remained, although both animals were getting better. And while both cohorts of animals improved over the duration of the experiment, that improvement was much more pronounced in the maize bright animals. And when he asked the students what they thought of their animals, these maize bright animals were sort of lovely, friendly animals with wet noses and not bushy tails, but the sort of rat that you'd like to take home to meet your mother and father, whereas the maize dull animals were surly and insolent, and in fact 3 of the students were bitten by maize dull animals. And in fact the experiment which Rosenthal had done wasn't on the animals at all, because they'd been selected at random from the same cages in the same animal house on the first day of the experiment. The only difference between them in their cognitive performance, and presumably also in their biting behaviour, was in the minds of the students, how that was reflected in the ways that the students interacted with the animals, and how that was then reflected in animal behaviour. So very important, but not done very much. When we started doing this, we were told that everyone knew that stroke researchers weren't very clever, and if we looked across the rest of the neurosciences, we would see how research should be done properly. We thought that was an interesting hypothesis. So here's systematic reviews. This is the stroke example I've shown you. These are transgenic studies in Alzheimer's disease looking at the effects of drugs in those transgenic models. And you can see when the investigator is blinded to whether that animals had drug or control, then the effectiveness is substantially and significantly smaller, and actually the 95% confidence limits overall barely get above 0. Here's the experimental allergic encephalomyelitis model of multiple sclerosis, same thing. Here's the 6-hydroxydopamine unilateral striatal lesioning model of Parkinson's disease, which when I was a bachelor student I was told was a bioassay. Well, it's a bioassay that only really seems to function if you're not blinded to treatment group allocation, because in these blinded studies the improvement in neurobehaviour which is observed is very much attenuated compared with those unblinded studies where the experimenters know what they're looking for, where their expectations perhaps are translated, are conveyed to the animals. So you can imagine we were then told, well, everyone knows neuroscience researchers are daft, not very clever, not very bright. Why not look at cancer? Why not look at HIV? Why not look at places where researchers know what they're doing? And again, we thought that's an interesting question. So in the UK, we used to have something called the Research Assessment Exercise, which was a government-led exercise running every 7 years to measure the quality of research outputs. And they do this under units of assessment, and several of those units of assessment can be mapped onto in vivo research. As an aside, in an excellent piece of nominative determinism, the RAE has now been renamed the Research Excellence Framework, so it's no surprise what they find. But even in the RAE in 2008, they thought that neurosciences were outstanding. And they were impressed by the strengths within the basic neurosciences and behavioural, cellular, molecular neuroscience, just the areas where we thought there was a problem. So what we did was we took the institutions which had performed best in those units of assessment enriched for animal experiments. And we selected the top 5 in the UK. I'm delighted to say that my institution was one of these. These are each of the institutions here, colour-coded to protect my future employment prospects. Lovely Scottish blue colour here. And the question we asked was, for those research outputs from those institutions for the 2 years after they were at the top of their game, in 2009-2010, what proportion of their studies reported randomisation? What proportion of the studies reported blinding? What proportion accounted for all the animals, inclusion-exclusion criteria? We put 10 animals in and measured outcome in 7. And what proportion did a sample size calculation? Chosen because these are considered to be cardinal features of reporting of an animal study, which allows the research user to do due diligence on the veracity, the provenance of the research claim which is made. And what we see is the reporting of rates of randomization of about 15% over the piece, of blinding of less than 20%, inclusions exclusions only around 10%, and power calculations at about 2%. 1 in 50 studies having a power calculation. And only 1 out of 1,000 studies did all 4 of those things. And 68% of them, 68% of the publications from the leading institutions in a leading biomedical research nation reported not one of those things. So this isn't a problem with stroke research. It's not a problem with neuroscience research. It's a problem over the piece, and a problem that we should really seek to do something about. And thinking then about quality in research, quality in academic excellence, well, I think there are 3 components to this. First of all, there's the inspiration. There's having the prepared mind that when you're sitting under an apple tree and something falls on your head, you begin to think about why things fall and what forces act on them. Or when you get into the bath and the water level rises, and you say, eureka. And really, institutions can't hire people on the basis of them being good at inspiration. And because most Nobel Prizes are awarded many, many years after the work was done, it has very little impact on an individual's early career, at least. But we can think about project design, having appropriate research designs at low risk of bias, having appropriate tools for data management, going through a process of ethical reflection, and pre-registering your study so that you say in advance what your design is, not flex your design and mould your design as the research progresses to maximise the signal that you get. And then in the actual execution of the study, reporting what you did transparently, doing an appropriate analysis, making an evidentiary claim which is appropriate to the data that you've collected and not inflated, making your material available to others, making your data available to others so that they can check your working, so they can try and replicate your findings, and disseminating your studies in a way that allows others to make use of them without having to pay the access charges to get in behind a journal paywall. If we think that the research that we do might inform the development of a cure for motor neuron disease or Alzheimer's disease, then we can't really be certain that the researcher who's going to see that happens to belong to an institution which has an institutional subscription, and so we cut out a large proportion of the research community who can't routinely access things that are behind journal paywalls. So this issue about research quality overlaps with research integrity, and I think it's important to define what we mean by research integrity. If you think about reasons why a study might not replicate, and this is from my university's response to the UK government's inquiry into non-replicability in research findings, we thought there were 4 broad reasons. Firstly, it could be that a valid claim was made on the basis of the observed data, but the statistical test was wrong. And we know that we have a type 1 error rate, false positive rate, type 2 false negative error rate, so that happens, it's part of the process. Secondly, it could be that the research claim was made was valid under the particular circumstances under which it was tested, but not observed under the circumstances in which replication was attempted. Now, these differences in circumstances may be obvious or subtle or completely latent. They may be unknown to the investigators at either end of this replication effort, and their impact on the observed phenomena may or may not be important in understanding the question at hand. That's to say, there may be latent biology driving this failure to replicate, which would be interesting if we were able to identify it. Thirdly, the observations that were made may have been made on the basis of a suboptimal study design, which for instance allowed the emergence of experimenter bias, selective data presentation, hypothesizing after results are known, which might generally be considered to be questionable research practices with varying degrees of researcher culpability. And by that I mean that if you're a researcher to whom it has been highlighted on a number of occasions that the way that you design your experiments is not optimal, and you continue to persist in designing experiments poorly with these weaknesses, then I think you begin to become culpable and guilty of not seeking to maximize your research quality. But of course we all have to start somewhere, and we all have to learn. And finally, the research claim may have been made following deliberate researcher malfeasance, falsification, fabrication, and the like. And the reason why I emphasize the definition of research integrity is that this category 3 problem is, I think, the problem where there is most room to improve the quality of our reporting of our work, of how we do our work, and of the scientific record. But we spend most of our time as institutions focusing on this category 4 problem. And I would define these problems, categories 1 through 3, as research integrity, reflecting the scientific integrity of a research claim, and this as being researcher integrity, that is to say, the integrity with which a scientist goes about their work. And it's important to recognize that these are different, and they might have different solutions to those different problems. Because researchers are different, we exist on a spectrum of behaviours from very poor to excellent, and perhaps optimistically I give a skewed normal distribution here, and we can define parts of this curve with falsification and fabrication and plagiarism, for instance, with hypothesizing after results are known, with doing experiments at risk of bias, and then things defining better performance like open science, open research practice, and finally optimizing what we do with pre-registering our study, registered reports and the like. And the problem is that our focus to date has largely been on these people with the most egregious behaviours here, trying to identify them, to escort them from our premises with their belongings packed in a cardboard box, pausing only to strip them of their library card and telling them never to darken our door again. And I think that is important, but it doesn't speak at all to the vast majority of researchers who are generally trying to do their best under what can sometimes be challenging and difficult cash poor situations. So with this distribution, that first approach is to identify the most egregious performers and get rid of them. But actually it makes more sense to say, well, can we, for every researcher, what can we do to help them get their research to be a little bit better? And actually, if you look at the value proposition for the area under these two curves, the value gain from everyone getting just 2% better is substantially higher than even if we get rid of the 15% most extreme research practices here. So improvement rather than a punitive approach being important. So we could implement things and observe what happened. This is a Story Landis's paper setting out the 4 things that you would want a paper to report for it to be credible, for you to be able to do due diligence on the research claim. Randomization, blinding, inclusions, exclusions, sample size calculation. You've heard those before. And following this publication, Nature, Veronique Kiermer had been involved in this process, and Nature set out a change in its editorial policy to require that this be reported for both in vitro and in vivo research. So looking first at the in vivo research, this is in blue Nature papers, so Nature and Nature Journal papers before and after the change where in this grey panel here, and in red non-Nature articles matched through PubMed related citations for the same topic area and for roughly the same time of publication. And here you can see the interrupted time series analysis with big upticks at Nature for randomization, less so in non-Nature journals. For blinding, less so. For exclusions, everyone seems to perhaps be getting a bit better, and for sample size calculations, lots at Nature, nothing anywhere else. So what they did seemed to work. These 4 things were the 4 things that I showed you earlier on from the UK institutions, and remember that in that study 1 out of 1,000 patients, 1 out of 1,000 papers reported all 4 of those things, and here by the end of the intervention, in the post-intervention period, 16% of Nature papers were reporting all of those things in their in vivo studies where it would be relevant. So it is possible to improve, but this was quite burdensome for Nature, and so they've started looking for other ways that it could be done as well. I just wanted to draw out from that study, though, where in vitro research sits, because in vitro research is often posited as an alternative to animal research, less ethical cost, can get lots of useful information. But remembering those numbers for randomization, blinding, exclusions and power calculations for the in vivo, then this. So this is non-intervention after the change. So the most contemporary data we've got. 3.2% even mentioning blinding, 3.2% even mentioning randomization, 1.2% mentioning blinding, about 11% telling us about exclusions, and 0.6% telling us about power calculation. So before we rush headlong into in vitro research as an alternative. Let's give it some thought. Thomas is going to talk more about the ARRIVE guidelines later in the most recent iteration. Part of the rationale for that was that the first iteration of the ARRIVE guidelines didn't really seem to be having as much effect as had been hoped. So the ARRIVE provided a checklist for authors to complete, and the argument went that if only authors were to complete the checklist, then we'd be done here, and we would get complete reporting and everything would be fine. So, led by Emily Senna, we did a randomized controlled trial because we thought this was an important question, an interesting question, where manuscripts submitted, we partnered with PLOS ONE for this. Manuscripts submitted to PLOS ONE were randomized to normal handling, which was where the author was sent a polite request for an ARRIVE checklist but no more, or intensive handling, where the author was told that unless they provided a checklist, their manuscript would go no further and would just sit on the editorial desk. And then we trained outcome assessors. We had each paper that of those randomized that was eventually published assessed by 2 independent reviewers, with any differences reconciled by a third. Randomized over 1,600 submissions, about 700 were accepted for publication, and you can see here the checklist was completed in about 3% of the normal handling. This is what happens when you ask nicely, and in about 90% of the intervention group. So it seems that perhaps some of the senior authors are on the phone to PLOS ONE saying, "Don't you know who I am? What is this ARRIVE rubbish? Di-da-di-da-di-da-di-da." Anyway, 90% of the checklist complete. So if a checklist works, we would expect to see something. And ARRIVE compliance was 0% in both of those groups. So it turns out that if you've got a fairly complex vehicle, so the ARRIVE checklist here, 20 items, but 38 items altogether, and we had to ask 100 questions in our review to work out whether our manuscript was compliant or not. Demanding that scientists fill in a checklist doesn't do very much good. So we need to think about other approaches to improvement, and we've been pushing the idea of research improvement as an approach, so formal approach improvement strategies, where firstly the community asserts what constitutes best practice, and it might do that on the basis, community of researchers themselves might do that on the basis of reporting guidelines, or research on research, or expert opinion, or what research users think, and we measure our performance, and then we try and improve our performance through training or incentives or interventions. And for instance, the equipped quality system is an intervention which has been designed to improve research practice. And then once this has had time to bed in, we measure performance again, and when we review that performance, we celebrate success. If our intervention hasn't worked, we think about other ways that we might approach the problem, and if the intervention has worked, then we say, all right, well, what's next? What's the next on our improvement list? Because we're trying to improve little by little by little by little, rather than painting a brand new revolutionary period of what a new normal is going to be. So research improvement is a process rather than a destination, and I hope that you can take that with you through the rest of the materials in this webinar and in subsequent webinars as a way of thinking about research improvement. Thank you very much for your time and your attention.